Yeah, welcome back, everyone. Vibrating voice. 1 second. I think Dr. Jamila is having some technical issue.
Yeah, and your this one you have not seen. Okay. Okay. Good morning, everyone. So, am I audible? ആരും കേൾക്കുന്നില്ല. Good morning, everyone. Put it in the slideshow. Do you want to wait for some more time? We can start. On your NICU staff at John. They know about it. Yeah, I sent to you. Yeah. We can get started. Yeah. This is your phone video is not visible. It's okay, maybe some problem with the camera. Yeah. It's okay. Yeah. Now it's go ahead. Close the door also. So good morning, everyone. So today's topic is on thermal care of newborn. So it is considered as one of the thermal care is the one of the major aspects of the neonatal care. So maintaining a normal body temperature is one of the most critical aspects in a newborn's journey that starts from birth to the entire neonatal period. So have you ever wondered what's the most complex adaptation in a human life is? So this adaptation that happens at birth, that is transition from a fetus to a newborn. And this transition has to occur very quickly for the survival of the newborn. Within few minutes, the newborn must transit from the protected intrauterine environment to a life outside the womb, undergoing rapid changes in the respiratory, cardiovascular, metabolic, and thermoregulatory systems. So during this process of transition, that's from intrauterine to extrauterine life, all organ systems are involved at some level. But the major immediate adaptations required for survival are the lung adaptation and the cardiovascular adaptation, followed by metabolic adaptation for the energy metabolism and for thermogenesis. The next is the most important component that is supporting this above transition, that is the endocrine surge that occurs during the late trimester and which get intensified during the labor. So this hormonal surge that helps to prepare the fetus for the abrupt changes that occurs at birth. And the key hormone mediators that include surge in catecholamines, cortisol, thyroid hormones, and the glucagon. So subsequently, we have this gastrointestinal and immune system adaptation happens that occurs in 6 to 8 hours of life. So each of these adaptations that occurs at birth, they represents a fascinating physiological transition. And this presentation will be focused only on the metabolic adaptation and energy metabolism and thermogenesis. So first let us understand why thermal management in newborn is so important and why we are so concerned with thermoregulation at birth. So compared to older children and adults, the neonates, they are more prone to heat loss. The reason behind is their skin is very thin, the blood vessels are very close to the skin surface, and they have reduced subcutaneous fat, and they have a high surface area to body mass ratio, which exposes their skin more to the environment and enhancing the process of heat loss and subjecting the neonate to the cold stress. In utero, the fetal temperature is stable and it is around 0.3 to 0.5 degrees centigrade higher than the mother. So what happens during the transition from intrauterine to extrauterine life? The newborn's body temperature drops rapidly 2 to 3, 4 degrees centigrade within the first minutes of birth on exposure to the cold delivery room or the evaporation from the wet skin. So what is the initial physiological response of the neonate to this cold stress? So the newborn, they try to assume a flex position in order to reduce their surface area. And also there will be a little bit of heat generated through the normal metabolic process that is mainly from the major organs like liver, heart, kidneys, and the muscle activity. But the two major key thermogenesis happens by the peripheral vasoconstriction and by through the metabolizing the brown adipose tissue. So these are the two key changes we have to be aware of in thermogenesis. It's the peripheral vasoconstriction of the extremities, which helps to retain the heat in the core, and the activation of the brown adipose tissue metabolism. So we all heard about brown adipose tissue. So this brown fat is specific only for the newborns. So its main role is to undergo the oxidation to generate heat, which helps in aiding the thermoregulation. And it's mainly concentrated in areas like nape of the neck, axilla, interscapular, paravertebral, and perirenal, and also in the mid-abdomen. And it develops between 26 to 30 weeks of gestation, making up to 2 to 7% of body weight. And the amount of this brown adipose tissue is directly proportional to the gestational age, and it continues to mature over several weeks postnatally, diminishing as the infant grows. Next comes the non-shivering thermogenesis. So what is non-shivering thermogenesis? It's the process of metabolism of this brown adipose tissue is known as the non-shivering thermogenesis. So this process is mediated via a norepinephrine-dependent signal transduction pathway due to the activation of the sympathetic nervous system in response to a cold stimulus. So as a result, when a neonate is exposed to cold, the first thing happens, there will be a release of norepinephrine into the brown fat, which activate the process of oxidation, leading to lipolysis and heat production. So in total, this process sets a chain of metabolic reactions leading to harmful physiological effects. So what happens when a neonate is exposed to cold stress and it is not recognized and it is not corrected promptly? There will be a cascade of harmful physiological events gets triggered, which increases the risk of the morbidity and in severe cases even to the mortality. So what happens with the continued peripheral vasoconstriction? there will be poor tissue perfusion, tissue oxygenation. This leads to increased anaerobic glycolysis, metabolic acidosis, and also this metabolic acidosis leads to reduced pulmonary perfusion. There will be pulmonary vasoconstriction, decreased surfactant secretion, decrease in the oxygen uptake by the lungs, and this will furthering the hypoxia and leading to PPH. So you can see how severe the sequence happens if the cold stress is not corrected immediately. So this is just the diagrammatic representation of the chain of events that happens on exposure to a cold stimulus. So what is the metabolic cost of this non-shivering thermogenesis? So the net effect is this process heavily consumes oxygen and glucose, risking hypoglycemia, hypoxia, and metabolic acidosis. And in addition, there will also be rapid depletion of glycogen stores, which is utilized for brown fat metabolism, and this will furthering the hypoglycemia. So this cascade of events, this has a significant impact on preterm and in hemodynamically unstable infants. So let's see how the newborns they present when they have a cold stress. So the presentation can vary depending on the severity of the hypothermia. They may have pale and mottled skin. They may have persistent acrocyanosis, and can sometimes lead to central cyanosis. Presents with the tachypnea, apnea, bradycardia, lethargy, and they can have poor muscle tone, weak cry, and weak cell. So now let's have an overview of thermoregulation. So what's the definition? What's the normal body temperature ranges, and what is thermoneutral zone? Or what are the methods of recording temperature? What's the mechanism of heat loss? And what's the role of incubator and radiant warmer in thermoregulation? And finally, what are the strategies available to prevent hypothermia in order to improve the survival and reduce the morbidity profiles that is the need of the hour? So by definition, thermoregulation, it is the ability to balance between the heat production and heat loss with the goal of maintaining a steady core temperature. So as discussed earlier, newborns are predisposed to heat loss, but they tries to generate heat by an unique means, that is by metabolizing the brown adipose tissue. So what is thermoneutral temperature? So when we talk about thermoneutral temperature, it's a narrow temperature zone between 36.5 to 37.5, where the newborn can maintain their normal body temperature. So anything beyond this thermoneutral zone, they have metabolic consequences. Like if there is a cold stress or even hypothermia, so both have their own metabolic consequences in all newborns. So these effects are very devastating when it happens to a preterm. So these are the normal temperature ranges to say hypothermia, moderate, severe, and hypothermia. So next comes the thermoneutral environment. So what we mean by thermoneutral environment? So thermoneutral environment means it just refers to the ambient air temperature that immediately surrounds the baby. And it also depends on where the baby is, the settings where the baby is being nursed. And this is a narrow environmental temperature at which the baby can maintain a normal body temperature at minimal metabolic rate, thereby minimizing the energy expenditure and oxygen consumption. They utilize their energy mainly for growth and other vital functions, and it varies by birth weight and postnatal age. So this is just a table representing the normal ambient air temperature, and this is mainly to the incubator temperature ranges. So again, if, for example, if you are having a baby in an ICU, when I talk about the thermoneutral environment, it refers to the ambient air temperature that is in the incubator. So the incubator, all incubators will have a thermistor, the probe is there, which continuously displays the air temperature. And if the baby is in a servo control mode, then this will get the probe will automatically it adjusts to display the air temperature in order to maintain the normal body temperature. And suppose if the baby is in a radiant warmer, so there is no closed air space. So this ambient temperature, air temperature becomes less relevant rather than the radiant heat that is being delivered to the baby. But still, the room temperature of the NICU matters to maintain the normal body temperature. And if a baby is in a bassinet, the ambient air temperature is the air that closely surrounds the baby, and it depends again on the room temperature based on the clothing, swaddling, and skin to skin care. So next comes to the methods of recording. As we know, regular temperature monitoring is very essential for all newborns. And the most common method we do at bedside is the touch method. That is, we just touch the hands and feet of the baby and the abdomen. And if we say it is warm and the hands and feet are cold, we say the baby is in cold stress. Or if the hands and feet and abdomen are cold, we say it is hypothermia. But this is not enough. The baby's has to be temperature has to be monitored using a digital thermometer by checking the axillary temperature. So, and also for continuous monitoring, we use the thermistor probe, especially when the baby is nursed in the radiant warmer or in the incubator. So here the probe will be attached to the skin over the upper abdomen, which will continuously display the baby's body temperature. Now let's see what are the mechanisms of heat loss. So we know there are four main mechanisms through which the baby can lose their heat. That is by radiation, convection, convection, and evaporation. So radiation, it means it's the transfer of heat from baby's body to an object that is without touching it. Mainly it represents the cold air walls, which is the walls which is near to the baby. And convection is the transmission of heat from body to the subject, which is coming in close contact with the baby, like a cold weighing scales, stethoscopes, etc. And convection is the heat that is carried away by from the baby to the cooler air that surrounds the baby. And evaporation is by transferring of heat loss from the wet skin and through the respiratory gases. So let's see what's the role of incubator in addressing this mechanism of heat loss. So the most commonly that we use in the intensive care unit is the incubators. So this is a closed, controlled and microenvironment which is designed to mitigate all four primary mechanism of neonatal heat loss. That is convection, radiation, convection, and evaporation can be mitigated through incubators. So let's see, it's interesting also to see how the incubator works. You can see the airflow mechanism, they work by the principles of forced convection. Okay, so what happens here, you can see here the fresh air or the air oxygen mixture is drawn into the incubator through a bacterial filter. And this air it is driven by an electric motor inside, and it is passed through a heating element and then through the humidification chamber, and this air is then driven into the hood in a laminar flow pattern. It is under low turbulence. So you can see there will be a current of air that will be circulating around the walls of the incubator. There's no direct air currents over the baby. So this is how the incubator works. So the main principle here is the forced convection system, where the step one is intake, propulsion, conditioning, and delivery, which I have already explained. So now how these incubators are considered to be better than radiant warmer by decreasing the insensible water loss and in the convective heat loss. So how it prevents all these four ways of heat losses. So first is by forced convection mechanism. So it prevents the convective heat loss. Then by using a double-walled hoods in the incubator, we can prevent radiation heat loss to the cooler atmosphere, which decreases the gradient. And the convective heat loss is prevented by using a pre-warmed heated mattresses or the warm internal environment. And by providing a high humidity environment inside the incubator, this will further counteract the evaporative heat loss. So here we have a single walled and a double walled incubator, and which one we have to choose. So the idea of double wall is, whenever we are asked to choose the incubator, it's always better to have a double wall incubator, because there's an air curtain in between the walls of the incubator, and this will provide a constant high velocity laminar airflow that covers the access port when opened with an invisible seal, which blocks the ambient air from entering the incubator. So always prefer to have a double walled incubator. So these are the humidification that we set in the incubator that's based on the gestation age. Usually it is recommended for babies less than 30 weeks of gestation. And this humidification, usually we start with 80 to 90% based on their gestational age and can be gradually tapered, weaned until 40% is achieved, or at least for 21 days, whichever comes the first. So this is again the table representing the percentage of humidity that we have to set in the incubator and how we wean the humidity over time. And usually by day 14, the humidity can be discontinued. So coming to the radiant warmer, so this is actually, it's an open cat system, which is very convenient and especially for managing babies more than 32 weeks. And it allows easy access to neonates for procedures and monitoring. But the only disadvantage of this is it increases the insensible water loss because it's an open cat system. And it works by the principles of producing heat using a quartz crystal heating element. Here, the heat is uniformly reflected onto the surface of the neonate by a parabolic reflectors. Again, we have two modes. There is a servo mode and a manual mode. So the servo mode of control is preferred over the manual mode. Here, which in the servo control, the heater output is based on the skin temperature that is in real time. And we usually set the skin temperature between 36.5 to 36.8 degree. And the room temperature has to be around 24 to 25 degree for the optimum functioning of the radiant warmer. And the manual mode, it is mainly allows the operator, we are the ones to determine the heater output, how much we need to give. And it is used during the resuscitation for rapid rewarming of a hypothermic neonate. And it's not routinely used because of the risk of overheating. And if a baby is on manual mode, the neonate's temperature has to be checked very frequently, often every 15 minutes. So if you have a sick neonate who is nursed under the radiant warmer, you can provide them with a cap, socks, and mitten, and keeping the chest and abdomen only the bare area for easy observation. In a stable neonates, they can be covered even except the face with appropriate clothing while the neonate is under the radiant warmer. If the neonates of preterms less than 32 weeks are being nursed in the radiant warmer, it's better always to use cling wraps, that is a mode of polythene sheets, which can be used to cover the bassinet, which will help in reducing the insensible water loss by creating a micro environment. Thereby, it increases the humidity to prevent the insensible water loss. So now let's see what are the strategies which are available to prevent hypothermia. And how do we improve the survival and reduce the morbidity profiles? So here comes the golden hour of neonatal life. That's the need of the hour. So there are the steps of the golden hour. That is the first 60 minutes of life. It starts with prenatal counseling and teamwork. So first we have to discuss with the management plan what we are going to do and answer all the questions, anticipate the parents' anxiety, and then define the roles and responsibility of resuscitation among the team members. Then we can defer the umbilical cord clamping for 60 seconds, then once the baby is born. And the third is mainly by preventing hypothermia. So here it's important for us to stick on to the 10 interlinked steps of warm chain. That is keeping a warm room, keep the delivery room and the recovery rooms free of air traps and heated at least to 23 to 25 degree. And dry the baby immediately after birth with a warm towel to stop evaporative heat loss. And the head has to be covered with a warm cap. Place the infant directly on the mother's chest immediately after delivery to use maternal body heat. Start feeding as soon as possible after birth, preferably within the first hour to provide energy and warmth. And delay the bath for at least 24 hours to prevent chilling. And again, dress the baby. Appropriate clothing is required. And if the baby is on less than 28 weeks, we can use the plastic wraps or the plastic bags. Keep the mother and baby together for 24 hours a day. And if the baby require transport and the baby has to be covered and bundled, if in a stable unit, or we have to use the incubator, transfer incubator if the baby is sick. And resuscitation has to be done under the radiant warmer. Use all warm supplies, even the equipments and drugs, and try to avoid cold items which are coming in contact with the neonate, and use heated humidified gases. And the last thing is, it's important the training and awareness, that is to educating the parents and the staffs on thermal protection. So these are the 10 interlinked steps that are involved in the warm chain. Okay, so this is the same thing which I have already explained. So then the fourth is the neonatal transport. So if it is required, the baby has to be stabilized, and they maintain the temperature and maintain the saturation more than 85 percentage before transport, and ensure the respiratory support is stable. The baby has an adequate respiratory support is maintained. Practice use of the CPAP in the delivery room. Use humidified heated oxygen, and practice on non-invasive ventilation strategy. And consider early rescue surfactant administration within the first hour. And LISA is preferred in infants with their spontaneous respiratory effort for the method of surfactant administration. Ensure the cardiovascular support is stable, maintain a normal heart rate, perfusion, and blood pressure. And detecting shock in the compensatory phase is very important. And early initiation of nutrition, like initiate breastfeeding immediately as early as possible, prevent hypoglycemia. Baby can be started on IV fluids if feeding is cannot be given enterally, and insert umbilical lines also if needed. And it's important also to stick on to the strict aseptic methods. The first dose of antibiotics has to be given as if indicated early, has to be given immediately. And the labs, the required labs like culture, blood glucose, and the blood gas, and the chest X-ray and the blood gas has to be obtained in the first hour of life. So, and also it is essential, it's most important is recording the interventions that happens during the first hour of life, that include the exact timings to evaluate the effectiveness of their care. So this records includes the Apgar score and all anthropometric measures, the axillary temperature on admission to the NICU, the vitals on admission to the NICU, the time and details of resuscitation interventions, all the invasive procedures, what's the size and what is the catheter tips position, especially with umbilical catheterization, and what's the start and time of fluid therapy, TPN, what's the depth of the NG tube that is inserted, what's the time and parameters for first feeding, and including the recording the complications that happened in the first hour of life. So this all these interventions to record is also important during the first hour. And lastly, so this during this first vital hour, there are a lot of interventions will take place in a stressful context in the NICU. So it's very essential for us to keep the family continuously informed about their child's condition and the care being provided. So, what's the evidence that it's available for us to support this golden hour management? If you are using a structured and a standardized protocol during this crucial first hour has shown there's a significant reduction in the neonatal complications due to hypothermia, and this has shown to reduce the incidence of IVH, hypoglycemia, chronic lung disease, and retinopathy of prematurity, and ultimately it improves the survival and morbidity profiles. However, the variability in practice in different NICU settings that remains a challenge, highlighting the importance of ongoing education, use of standardized checklists for the units, and the need of multidisciplinary collaboration. And the most important or most essential, that is ensuring commitment to the golden hour principles to reach its full potential. So the key message is that every newborn, they deserve a warm start to life. Effective thermal care is a simple, it's a low-cost intervention that significantly improves the neonatal outcomes and survival. Thank you. Any questions?
Thank you very much, Dr. Jamila, for that comprehensive coverage of this very important topic. Any questions anybody has? So, one question that is most often asked by parents, especially first time parents, is what should be the room temperature after they go home? What you've
Mm.
spoken to mostly is it pertains to our hospital environment, right?
Mm,
But
mm.
also at home, correct? But at home, what would be the ambient temperature that is advisable, given that most newborns are given to maximum minimum 2 layers of clothing. They have an inner vest, and then they have an outer sleep suit,
Mm.
plus they are swaddled. So given this scenario, what will be your advice to parents?
Again, it depends. The ambient room temperature to set, we normally recommend 23 between to 25. Again, it depends on the environment. If it is very hot climate, you don't ask them to overwrap the baby. It may even increase the temperature of the baby. And we also advise the mothers to check the baby's temperature. That's at bedside by the touch method. If they feel the baby is so hot by touching because of their overwrapping, they can use loose clothes to cover the baby, or if they feel the baby is cold to touch, then they can use more clothes. So it depends on the environmental temperature too.
So when you say touch method, touch on the forehead,
Mm.
or
No, hands
the
and
hands
feet
and
and
feet,
tuck them
hands
in.
and feet.
That's what the
Yeah,
hands
because
and feet and tuck them in.
the head is usually warm
No,
up until
it's the hands
yeah,
and feet, the extremities, and then the
yeah,
abdomen.
right.
So this is as a bedside assessment, and if they feel so, they can do accordingly. And they can then it has to be checked with the digital thermometer, definitely.
Thank you. Any other questions? Very often, when we are dealing with an emergency,
Mm.
um, um, temperature seems to be taking a back seat. So I
No, the
think we need,
first thing to do,
the first thing to do is to keep this in mind. I mean,
especially,
extrapolating this to even older infants and older children, keeping the ambient temperature, uh, optimizing the ambient temperature will be important in part of the resuscitation.
yes, even in newborns, if the baby's body temperature is not normalized within 10 to 15 minutes, or the maximum is to 20 to 30 minutes, this will sets a cascade of events. I have shown you the
Mm.
chain of events which will sets in. So once the baby goes into a state of anaerobic glycolysis or metabolic acidosis, then all events happens together. Then you have to manage the complications only.
Right.
Hi, Doctor. Thank you for this lovely presentation. I just want some points on how about the kangaroo mother care? Has got anything
Yes,
to do with
yes.
how effective it is
KMC.
in for maintaining the thermogenesis?
Yes, definitely it has a major role. I know I have missed
Hello?
that part
Yeah.
of kangaroo mother care. So KMC has a definite role in keeping the baby. That's one way we say if a baby in a stable neonate, the immediate skin to skin contact, that's one way. And especially this KMC is also for preterm babies less than 32 weeks, we do this KMC, especially in the NICU setting, even in sick babies on ventilator also we can practice this KMC, which provides to maintain their normal body temperature, or it enhances the thermogenesis better.
So come winter, I know Bahrain tends to get very cold a couple of months.
Mhm.
So what is the kind of heater that is advisable for parents to use? Um, we
Heater.
have different, yeah, to keep the room temperature, to optimize the room temperature.
Uh, in cold environment, it's normally we recommend to keep for a baby 23 to 25 is the room temperature to set.
No, which is true. But then
Hmm.
in winter,
Hmm.
the environmental temperature goes down to say 10, 11. So in that, which case,
Hmm.
We will have
They
to
can
refer
swaddle,
you to.
it is by swaddling the baby, then cover the baby. They can use 2 clothes or 3 clothes. They can use some blankets to cover the baby. And with the caps, mittens, shorts, everything.
Yeah, my question was there are
Mm.
different types of heaters, room heaters. So, which is the room
Yes.
heater that is advisable? There is one that is a direct
Mm.
radiant heat, which
The
heats up the room
heaters
air.
to use inside the room, just
Heaters, room heaters, yeah.
I'm not sure about any specific heater methods, but ultimately we had to maintain the room temperature in this particular range. And if we feel cold, even our perception also on cold, if we feel we can cover the baby, it is the number of clothes that we use to cover the baby and swaddle. And then we can also ask the mother to say, you can touch and see the baby. If you feel the extremities are cold to touch, you use more clothes to cover the baby. Or if you feel very warm, use loose clothes. So that's only the advice we will give to the mothers.
Mm, all right. If there are no more questions, I think we'll close the
Close.
meeting. Thank you very much once again, Dr.
Thank you.
Jamila.
Thank you.
It was a very informative session. Thank you.
Yeah, these adaptations are very interesting. If the lung is different, cardiovascular is different, which happens at birth, that is fetus
Mm.
to a newborn.
Maybe we can have a session just for that.
Yes, each one is a
Adaptation.
separate session.
Yeah,
Yeah.
we could do that. Mm?
Okay.
Yeah.
Okay. Thank you, doctor.
Thank you. Thank
Thank
you.
you.